everybody, and good afternoon. I'm Greg Worrell, General Manager of Pace Care, and I'd like to wish you all a welcome to the second in our series of webinars. We'll acknowledge the traditional lands on which we all meet today and pay respect to the elders past, present and emerging. I'll just cover off on a few quick housekeeping items before we get started. As we've got quite a number of attendees today, our questions will be answered towards the end of the presentation, and the Q&A session will be facilitated today by Emily Miller of Brilliant Logic. All pre-submitted questions have already been given to Tina, who will do her best to address as many as possible. And any additional questions that you may have arising during the seminar can be submitted using the Q&A function on the bottom right-hand corner of your screen. Slides and videos of the webinar and contact details will be sent to you after the webinar. Okay, so in our last webinar, we touched on the challenges faced by care service providers in dealing with significant and ever-increasing financial, legislative, compliance and social pressures. And our last webinar was very much preemptive and focused on financial aspects. We've now had an opportunity to review the final report of the Royal Commission into Aged Care, and more recently, federal government responses are now emerging, giving us somewhat more of an idea of the direction we're headed. Now, in this webinar, we'll turn our attention to meeting quality in care and safety expectations following those Royal Commission recommendations. I'm pleased to present our keynote speaker today, who is Tina Sinclair, a director of O'Connell Advisory, which is a boutique consulting firm that specialises in health, aged care and disability. Tina's background has almost continuously provided advisor services to residential aged care providers under sanctions, specialising in operations and governance over the last 7 years. I welcome Tina now to share with us her insights and thoughts.
Good afternoon, Greg, and thank you for your kind introduction. And thank you for everyone joining us today. So, the pursuit of quality and expectations in quality and care and safety post the Royal Commission. I thought it just might be useful to start off by putting things in context. So, in 2015 and 16 budget, the Commonwealth announced there was funding to develop a new set of aged care quality standards with the aim of having the consumer at the centre of care. In 2016, concerns about the treatment of the person accommodated at Oakden in South Australia resulted in both a state and national review. The national review concluded in October 2017, and recommendations including the establishment of a new and independent Aged Care Quality and Safety Commission, unannounced visits, and the establishment of a serious incident reporting scheme. In July 2018, the aged care industry commenced a transition to the then new current standards. The guidance and resource document released includes reflective questions that underpin the requirement of each standard. This has actually been an invaluable resource, and I commend this document to anyone struggling to understand what is required to demonstrate compliance. The Royal Commission into Aged Care and Safety was established in October 2018, and the new Aged Care Safety and Quality Commission commenced about 3 months later. And it's become apparent that following Oakden, the prior accreditation agency was adopting a tougher stance, and the Commission has implemented a culture of change. In my view, the stance change from being able to identify areas of non-compliance and demonstrate actions underway to address them being considered acceptable to an expectation of being compliant at all times. Now, the Royal Commission ran it for about 2.5 years with an interim report, and were delayed to some extent by the start of the COVID-19 pandemic, which, while it wasn't official until March 2020, we're starting to see implications emerging in December 2019. And unfortunately, we had outbreaks both in New South Wales and Victoria. With 61 cases and 30 deaths in New South Wales, Victoria, 1,988 cases and 655 deaths in residential aged care settings. The Royal Commission had its final report delayed until February this year as a result, with 148 recommendations and the Commonwealth Government providing its response in the recently announced May budget. In this webinar, I'm going to be reflecting upon the recommendations made as they relate to the current aged care quality standards and considering how this could impact on providers moving forward. So, of the 2,722 residential aged care services as of the end of last year, up to 43% had site visits, although this could be lower as some providers have two IDs, and it's possible some might have had at least 2 visits. I'm aware of having some services having extensions of their accreditation, but it should be noted that extensions are granted on the basis of risk, including previous issues of non-compliance. Standards 2 and 3 continue to be the standards often found non-compliant, and this is often due to the fact that there's a relationship between the standards, the failure to provide safe and effective personal and clinical care, and the failure to manage the high impact or high prevalent risks in Standard 3 will lead to reviews of risk management, clinical governance, and overall organisational governance as part of Standard 8. It is interesting to note the increased non-compliance in Standard 5. I suspect this will be actually in response to facilities with multi-bed wards, which are not in line with modern contemporary standards, but also those that have not been purposely designed to allow ageing in place across the spectrum of needs. From this data, it's evident that the Commonwealth Commission's focus has been on residential services rather than home care services. The issues of non-compliance continue to be with standards 3 and 8 for the reasons I've given above, but I do anticipate with the increased number of home care packages and following the growth of providers in the space when the system changed to allow more competition, there'll be a greater emphasis of home care providers in the next 12 to 18 months. For those home care providers in the audience, I'd strongly recommend, if you have not already done so, take a gap analysis of the requirements of each standard using the reflective questions. The important focus here, and this applies to both residential and home care service providers, how do you evidence you do what you say you do? Policy and procedure alone is not sufficient evidence. There needs to be records and documentation readily available for review to demonstrate that you do in fact do what you say you do. There will be observations taken and consumer and representative feedback elicited to allow assessors to triangulate and draw conclusions based on what has been found. So be prepared. This outlines the regulatory actions undertaken following assessments of non-compliance from July 2020 to February 21. One of the issues I have with this data is that the Commission will publish a data set which includes those for whom a regulatory action is yet to be determined. And that's completely understandable given the process for providers to respond to assessor findings. I suppose what I would like to see is that the data is updated subsequently. Of interest was the increase in notice to agree, which seems to be a level between notice of non-compliance or sanctions. And I think it would be helpful if we actually got some indication of where it sits within the regulatory strategy. Obviously, the volume of notice to agree and sanctions in July, August last year was probably most likely a result of the COVID-19 outbreaks at various facilities and the Commission's response. The increase in February this year suggests that the Commission is returning to a more normal pattern of on-site activity, which was curtailed last year as a result of the pandemic, whilst the risk of community transmission remained as probable. The first recommendation, a new Aged Care Act, and we know that this recommendation has been embraced by the Commonwealth Government. There is emphasis upon a number of items which are already explicit in the current aged care quality standards. The language puts further emphasis on key outcomes, for instance, recipients having active, self-determined and meaningful lives. Standard 4 services and supports for daily living requires organisations to provide safe and effective services and supports for daily living that optimise the consumer's independence, health, wellbeing and quality of life. I would expect, in light of this recommendation, there will be a further focus by the Commission on ensuring all services are targeted at optimising consumer independence, including ensuring that consumers are enabled to do as much for themselves as they are willing and able to do. In a home care setting, this is probably more manageable, as consumers have a limitation on the funding package, and sometimes it's around their choice. However, this is more of an issue in the residential setting, where there is an implicit assumption that care and services should be delivered by the home. For a traditional housewife, meaningful activity could be doing the things they used to do, as assisting with food preparation, setting tables, cleaning, or laundry. Irrespective of service settings, providers need to ensure that they undertake good social intake assessments and understand what was and is meaningful to the consumer. Once they understand what is meaningful, then they need to assess how they can best support the consumer to achieve this. For one residential care provider, this meant allowing one Italian mama into their kitchen, ensuring she'd had training in food safety, and she was able to direct and to the best extent participate in the preparation of a meal every so often, mindful of food safety requirements. I should add that these meals were actually really well received by the other consumers residing in the home. The second point is actually in my view, very aspirational, but here I think the emphasis will be on the safe and caring environment for dignified living. As I mentioned before, I'm starting to hear indications of an additional emphasis on environment, particularly with facilities that have multi-bed wards and older stock. And there it's about how can you actually provide dignified living in a multi-bed environment. I expect to see a greater emphasis on preventing abuse and neglect, particularly on the harm from poor quality or unsafe care in light of the serious incident response scheme. Home care providers are not exempt from preventing abuse and neglect and should ensure that they also educate their staff on what abuse and neglect is and what they should do if they see any actual or potential instances occurring for the people they live and care for. This may require the introduction of anonymous reporting and would certainly require whistleblower protections. As already outlined in the current aged care quality standards, choice and control are key, and I would expect additional scrutiny by the Commission on how providers are demonstrating that the consumer has choice and control in the care and services delivered. And I'm actually going to touch upon advocacy and complaints mechanisms further in this presentation. Whilst the Aged Care Charter of Rights was implemented in July 2019 and should be routinely included as part of the admission or intake process, I'd suggest, in light of this recommendation, that there will be a further emphasis on ensuring ongoing education and awareness raising of consumer rights whilst they continue to be residing in or a client of your particular service. I'd recommend to providers that consumer rights should be promoted as part of ongoing consumer communications. The board may wish to review their vision and values to include some statements on supporting consumer rights and how this will be monitored and measured. The right to presumption of legal capacity is a challenging one, particularly when there are families involved who rightfully or wrongfully are assuming they are able to make the decisions on behalf of the person they care for. There is an expectation by the Commission that providers advocate on behalf of the people they care for. I think this advocacy has to start at day one, when engaging with the care recipient for the first time, including any people they wish to have involved, and challenging any assumption re lack of legal capacity without appropriate review from a qualified practitioner. I also strongly recommend that as part of end-of-life planning, anyone with legal capacity be encouraged to consider what they would like for planning in the future in the event they lose the capacity, whilst they still have the right to make that decision. I think irrespective of legal capacity or not, the sector should be adopting the principle espoused by disability, which is not about me without me. Just because someone does not have the legal capacity to make decisions doesn't mean they can't give meaningful feedback about their preferences. Even people with dementia who are still able to have some input should be included in discussions about the care and their care needs and their preferences for care. Now, just looking at the last 2 dot points on the slide, I think they're actually intertwined. People have the right to non-discriminatory treatment and the right to provide an opinion or a complaint without fear of retribution. In a residential context, this is actually the consumer's last place of residence. In a home care setting, the consumer is dependent upon the care and services being delivered by the provider to enable them to remain in their home. The threat of becoming homeless or being forced to leave your home for fear of retribution when you are vulnerable is very real. Providers need to regularly review consumers and monitor their competence to be able to make a complaint safely. There are a number of recommendations that touch on assessments and care plans. If you haven't already done so, I would urge each consumer to review the suite of assessment tools available. They must be evidence-based and best practice. Make sure you have competent people available to undertake the relevant assessments and that assessments are being reviewed and evaluated periodically or as needs change. Home care providers are not exempt from this clause. If you have someone who's been assessed by ACAT or the Regional Assessment Service as being in pain, you need to ensure there are strategies not only to support the person who is in pain to do what they can and remain at home, but there are strategies in place to ensure that the person is able to manage their pain. Depending on the issues identified, you may need nurses for clinical issues, physios or OTs for mobility and dexterity, as well as social assessments. Care plans not only need to reflect needs, but need to reflect preferences. You need to know your consumers and what they prefer. Do they have cultural requirements for a female carer? Do they prefer to receive their showers or baths in the morning or afternoon? How does their care and services optimise them to live their life the way they want? Make sure there are mechanisms in place that these are reviewed and adjusted as care needs change. Many of the clinical management systems actually do have these mechanisms. However, in our experience, staff are either unaware of or ignore these prompts, which will bring you undone if there is an unannounced visit. If you don't have a system in place to ensure assessment and care plan reviews are done regularly, do so. Adopt a partnership model with other key stakeholders such as family, friends, other service providers and other key stakeholders and develop a case conferencing schedule so this occurs routinely or as needs change. Irrespective of whether you're a residential or home care provider, there is an expectation that care and services are managed appropriately where there's an identified need. Where you are delivering any clinical care, you must have appropriately qualified and skilled staff who are able to evidence best practice in the management of clinical care in the domains I've outlined. Providers may outsource some of these services, but you still need to ensure that your consumers are receiving safe, appropriate care. Your clinical governance framework should include mechanisms to monitor and measure this, including clinical indicator trending and analysis, and periodic audits of clinical practice and documentation to ensure ongoing compliance. Ensure that your workforce receives relevant education across the relevant clinical and care domains. And there are free online training resources available from Dementia Training Australia and on End of Life from Palliative Care Australia, which are recommended. I thought this graphic would be helpful in identifying how looking at one issue can then lead an assessor down a rabbit hole, which can lead to findings of non-compliance with a range of standards. Clinicians and carers need to make sure that they take a holistic approach rather than just considering one particular domain. When reviewing incidents, an auditor may identify a consumer who has frequently displayed aggressive behaviours. This aggressive behaviour could be due to uncontrolled pain or constipation. You then could start looking at pain management that can then lead to medication management issues, or continence management, which can then lead to continence management issues. Is the consumer getting sufficient quality sleep, or is there a sensory issue which is causing frustration? Is the consumer sufficiently engaged with activities of interest or diversion? Is there an underlying infection contributing to the behaviour such as a UTI, which then leads to consideration of antimicrobial stewardship? Have the changes in behaviours led to reassessment, and have care plans been reviewed and updated? Has there been a case conference and referral to appropriate specialist to support behaviour management plans if all previous interventions are no longer effective? Care management should be core business for any provider, and it's a sad indictment on the submissions received that these recommendations were considered necessary. Make sure, again, you have appropriately qualified and skilled staff available to coordinate care management for consumers, particularly those with complex care needs. Again, the importance of knowing the needs, goals and preferences of your consumers are critical. Dissatisfaction is the outcome of unmet need. Being able to anticipate consumer needs and the investment of 10 minutes upfront to set them up for the day ahead can save an hour or more subsequently responding to that unmet need. The need could be physical, clinical, emotional, or social. Care and service plans cannot be generic, as one size does not fit all. There needs to be consideration of consumer preferences on the planned care day. When on site at residential aged care facilities, I see too often a majority of consumers showered and dressed for the day and either seated at the dining table with nothing to do, or in their rooms snoozing fully dressed, often by about 7:15 in the morning. I dispute they're actually receiving care and services in line with their personal preferences. This to me indicates a task-orientated staff culture where the staff just want to get things done and dusted. If I ever get to the stage of requiring residential aged care, the last thing I want to do is to be showered, dressed and ready for breakfast by 7 a.m. How many of us would choose this? Give residents the opportunity for quiet waiting. As long as there's breakfast options available across a reasonable time frame, it's not an issue. Care and service plans should also reflect the consumer's nutritional preferences. An analysis of consumer preferences across the spectrum of consumers should influence menu selection for the facility or the service. Moving forward, it will be important to consider having vegetarian and gluten-free options, which may well extend to vegan options if consumers have a specific preference with the new demographic soon to require aged care. It may not be necessary to have these cooked fresh. It could be that you outsource in consultation with the consumer. These days, there are options to access kosher and halal certified pre-prepared meals if necessary. After all, the practice of fish on Fridays came out of religious requirements when Australia was largely Christian in faith. From a cultural perspective, it may just be negotiating with the consumer on the number of times that a meal specific to their culture is served. Or it could be as simple as ensuring that a bowl of rice is served with the meal. Partnership in care is something that is often overlooked. Case conferences should be attended by the consumer, the authorised representative in place, any other person that consumer wishes involved, the GP if they're available, care manager, and any other provider of care and services who are involved with delivering care to the consumer should be involved to ensure a holistic approach to care and service delivery. In a residential context, also include the lifestyle coordinator. This is often an ideal opportunity to review care and service plans and determine how best to meet the goals of active, self-determined and meaningful lives to the best extent possible. Unfortunately, we're not yet seeing comprehensive understandings of the current requirements in relation to restraint. Now, restraint is defined as any practice, device or action that interferes with the care recipient's inability to make a decision or restricts their free movement. Authorisation must be obtained before using any restraint, even if the intent is not to restrain, but as resident choice for their comfort, such as the use of bed rails. The only exception to this is if it is an emergency situation and it is not practical to obtain authorisation beforehand. Restraint should be an intervention of last resort and only used when other interventions have been ineffective. It is imperative that it is recorded somewhere that other interventions have been offered and evaluated as ineffective before the restraint is utilised or administered. The use of restraint should be reviewed periodically and re-evaluated for effectiveness, and authorisations also need to be reviewed periodically. Chemical restraint is the administration of any psychotropic medication without a relevant diagnosis, irrespective of whether this is a regular medication or PRN. Clinical managers should ensure that they access information on this full range of psychotropic medications. Make sure your psychotropic self-assessment tool is maintained up to date and current consent for administration on file. I continue to be bemused by the amount of facilities I visit where this is not in place. If it hasn't been authorised, don't administer unless it's an emergency situation and it's not possible to gain authorisation beforehand. Environmental restraint includes any systems in place that prevent a resident from freely entering or exiting their residence, including perimeter fencing. I'd recommend for any security systems, move to a keypad system and provide the keypad number to those residents for whom environmental restraint is not indicated. If it requires another's intervention to enter or exit, it is environmental restraint. I think it's likely that any use of unauthorised restraint will be reportable under the Serious Incident Reporting Scheme moving forward. Home care providers, do not consider yourself exempt from considering restraint. The Commission has an expectation on providers to advocate on behalf of their consumers. My expectation would be that you educate your workforce on restraint and have a system in place to advocate on behalf of consumers who may be subject to physical or environmental restraints. The recommendations arising out of the Royal Commission report are consistent with that of the disability sector, which requires any type of restraint to be authorised, even if it's down to locking fridges or drawers, and requires access be given to all others who do not require this restraint, such as keys to the fridge or drawer. As residential facilities are purposefully designed to limit access to certain areas, I'm not sure how this will play out moving forward, and I hope there's going to be some consideration of this when a decision is made. Every provider should have profiles of their consumers' diverse cultural and spiritual requirements. Some consumers may not elect to identify as diverse, but irrespective, all your workforce should be educated on ensuring that they are non-judgmental and leave their personal beliefs at the door before commencing work. And I'd suggest this should even be part of your screening process on recruitment. It is important that your workforce understands what cultural safety is and what they can do to ensure that people they care for feel safe to express their culture, beliefs, and diversity without fear of repression. Trauma-informed care is becoming more widely accepted, particularly in dealing with people identifying as Aboriginal or Torres Strait Islander who may have been impacted by the stolen generations. Another group are war veterans. Refugees and first responders would also benefit from a workforce better educated on delivery of trauma-informed care, given they are likely to have experienced trauma during their lives. There are great resources available, including a quality improvement audit and implementation resource for developing a trauma-informed organisational and practice culture. Organisations should also focus on ensuring that as part of their action plans, they include implementing the aged care diversity framework, particularly in those areas where the demographics indicate people from a range of diverse backgrounds, be it culturally or otherwise diverse. There will be a particular emphasis on ensuring cultural safety and culturally appropriate services for people of Aboriginal or Torres Strait background, given the issues identified with this group in accessing culturally appropriate services, noting that a mainstream approach can conflict with what is considered culturally appropriate. Excuse me. I think I've already alluded to this a number of times, but ensure that your workforce have the right skills, qualifications, and experience. And this should be able to be evidenced as part of your recruitment process, and then there should be evidence that they are supported through the provision of appropriate training and development whilst they remain part of your workforce. I would also suggest, if you haven't already done so, review your workforce to ensure that there's sufficient delineation between the various roles and responsibilities, and people are working within their scope of competence. Unfortunately, the team seems to have been a bit of a blurring of the lines, so I always recommend that this be looked at. Again, ensuring that they are sufficiently trained to ensure that they know and can respond to people with dementia, that they understand and can support advanced care planning, and they're also knowledgeable about what to do at end of life, including provision of palliative care. As part of the recommendations made by the Royal Commission and acceptance by the Commonwealth, we know that at some stage there will be a requirement for residential aged care providers to demonstrate that they have sufficient ratios in relation to care and clinical staff. I would actually, for residential providers, recommend that you actually set up systems in place and monitor your care and clinical staff times now and understand your current ratios. So if you are currently below, think about how you can actually achieve that, noting that there are funding limitations. In light of the recommendation that the Minister refers certain matters for urgent review by the Australian Commission on Safety and Quality in Healthcare, including provider governance, I would expect further focus upon clinical governance. I'd recommend that if you haven't already done so, do a gap analysis of your current clinical governance framework against available standards to identify and remedy any gaps. In my view, I actually think that the Aged Care Quality and Safety Commission is somewhat stronger in considering other aspects of governance as opposed to the clinical governance. I would suggest that providers also review their boards to ensure there's a range of relevant skills across the board. I myself am a board member of a regional aged care and disability service provider, and I like to think that the value I add to the board is industry knowledge as well as a strong appreciation of the requirements of the aged care quality standards. Think about this. Most boards will have someone who is strong on financial governance, be it an accountant, as part of its composition to ensure sound financial governance. So why shouldn't this be the same for an organisation providing clinical services? It is my view that there should be an independent board member or advisor with the right qualification, knowledge and skills for the board to assure itself in relation to clinical governance. It may well be that boards move from being voluntary to paying members or advisors to ensure not only they attract people with the right skill sets, but there is a commitment, as in there would be an expectation of value for money. Again, it is actually, I've already touched on the fact that it's so important to ensure that people feel safe to make a complaint. And if you aren't already doing so, make sure that you're regularly reviewing and discussing with the consumers their views on whether or not they actually feel safe to provide feedback or make a complaint. Make sure that your workforce are educated on what they need to do if they receive a complaint. Often there can be an expectation that someone is dissatisfied. It's just part of their nature. It's just Mary, she always complains. Don't accept that. Make sure that if someone is frequently raising an issue, that you have captured the data, that you've analysed it, and there is evidence that you have done as much as reasonably possible to resolve the complaint. Now, it may well be that the person has unrealistic expectations and everything that you can do will never satisfy that person, but make sure you've got the evidence in place to support that. If you aren't already doing so, set up some categories so you can actually analyse thematically your complaints and make sure where you've identified an issue, that you're identifying opportunities for continuous improvement. Use the Aged Care Quality and Safety Commission. Do you have a concerned resources? They're available in a wide variety of languages, and they actually help you to demonstrate that you're actually supporting the consumer to understand different avenues for making a complaint. The other thing I strongly recommend is that you actually ensure that you've got evidence in place, that you are taking an approach of open disclosure in dealing with complaints and incidents. Not only the expression of regret, but also that you're actually being open and transparent with the complainant on what the results of investigations were, and involving the complainant and testing the resolution. And if you're not already doing so, following up subsequently to make sure that the complainant is satisfied with the response taken and it has been effective. Again, the fact that advocacy has been raised as an issue in the Royal Commission surprises me, because there are advocacy services for older people readily available. I think part of the issue is that workforce and consumers don't necessarily know what advocacy is and how it can actually be of benefit to them. Now, the Older Persons Advocacy Network, which is the Commonwealth-funded advocacy service, is actually very well resourced and very well able to assist not only in dealing with individuals, but also organisations. So if you're a provider and you're having an issue with an individual, sometimes OPAN are able to provide support in resolving it. And again, the state-based organisations are also available. So ensure that both your workforce and consumers know what advocacy is all about, and even in the event that they need it, how they can actually contact these organisations. The Commission takes a risk-based approach to assessment contacts, and this is outlined on their website. The determination of risk will be influenced by a number of factors, which will include prior history of non-compliance, complaints, serious incident reports, and outcomes of assessment contacts undertaken, which can also be desktop. We also understand that undertaking significant capital redevelopment is also a flag for residential services. So the higher your risk profile, the more likely there is a chance of an unannounced assessment contact. In my experience in undertaking independent assessments, many providers are just simply not prepared. The Commission's website has schedules of risk-based questions that are asked on commencement of contact assessments, and they do differ from home care to residential. Ensure your management team know what the risk-based questions are, and that there is a system in place to have the information readily available, even if it's just updated on a weekly basis. There's also an information request, again available on the Commission website. Have a system in place so that the information can be accessed quickly. Liaise with your client management system provider to ensure you know which reports will give you the information you need. If they aren't there, request that they be made a feature of the system. And I happen to know that one one vendor is actually working on having these all available shortly. This is an industry-wide issue, so vendors should be responsible. As we saw previously, there was a move to undertaking assessment contacts after hours or on weekends. This seems to have reduced, but it is entirely possible this will start to reoccur. Make sure that those in charge after hours or on weekends understand what will be asked of them in the event of an unannounced contact and how they should respond. Also, educate your workforce on what to expect, because the more prepared they are, the less likely there's going to be lots of sick leave taken in the event of an unannounced contact. They should know where to find policies and procedures, where to find outbreak management kits, principles of infection control, and what to do in case of an emergency. I would also expect that they're tested on their understanding of the Serious Incident Response Scheme and their responsibilities in relation to elder abuse. Two key messages I always give. Don't say, I don't know. Say, I'm sure, let me find out and get back to you. which gives them the opportunity to either find the answer or find someone who can. The other thing I also say is if you see an assessor, don't look down, try to run away or open a door, go into a room and close it behind you, because it just actually makes people think there's something to hide. If you can see us, look them in the eye, smile and do your best. If staff are properly prepared, assessment contacts should not be a challenge. This is stating the obvious, but what I'm seeing is there's some complacency creeping back in relation to infection control. Whilst a number of facilities now have consumers vaccinated, there still may be some consumers who have refused the vaccination, and that's their choice. If this is the case, there's still a need for a current outbreak management and COVID-19 management plan, and they need to be maintained as current, particularly if there's been a change in key contacts or you've had some reconfiguration of your facility. Ensure that if there's been any recommendations made by the Commission or other reviewers, that these have either been actioned or there's a rationale as to why this wasn't actioned and there's evidence in the documentation. Make sure your infection prevention coordinator is appropriately qualified, as people do change over time, roles over time, and are undertaking their responsibilities. They need to actively monitor staff who may be less diligent about hand hygiene as the incidence of community transmission has decreased. Promote the importance of vaccination in your community. In a residential setting, again, all may not have been elected to be vaccinated, and over time there'll be new people coming in, some of whom may not yet be vaccinated or have chosen not to be vaccinated. Keep promoting the importance of hand hygiene, not only within your organisation but the community, because in my view, infection control will continue to be an area of focus for some time yet. Okay, that's about it for me. So Emily, do we have any questions?
We do. Thank you so much, Tina, for a fascinating presentation. We have had a few questions come through during the webinar as well as submitted in advance. So we don't have a huge amount of time, so I'll just get straight into it. Question in advance, how do we balance the high compliance load and expectations with employee workforce challenges?
Oh, it's a really hard one, because unfortunately part of the impact of the aged care standards is a requirement to document everything as evidence. Again, I go back down to impact upon workload and the importance from your care and clinical staff, and the importance in a residential setting of setting your consumer up right for the day, because that additional time taken to set the consumer up, make sure they've got everything they need and are feeling happy and comfortable, can then reduce the requirement for a lot of time to actually address the consumer's dissatisfaction or other negative outcomes taken because you didn't actually put that investment of time in. I think, again, thinking from a consumer-centred perspective is important. The other thing is the impact on workload. Again, in that setting where everyone's being woken up at 7 o'clock in the morning, shower, 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 shower. If Betty decides she doesn't want to get up to 9 o'clock, it actually releases the urgency on the care staff to go ahead and do all those showers at once. They can actually be staged across the day. So I think yes, I'm not saying that working in aged care isn't hard work. I appreciate how hard it is, but it's about thinking about how you work smarter, not harder.
Thank you. And a question just submitted just then. So in terms of when complaints are received, most often the complaints are not evidence-based. How do you deal with complaints in those instances?
I think part of it, sometimes people complain based on perception. People are never going to be dissatisfied, but sometimes it can be just indication they feel that they want to be heard. So find the evidence for it, and sometimes you might have to tell the consumer that. But at the end of the day, if Betty's making a complaint about care that's, she, in her view, is too rough, and you've done everything reasonably possible to try and investigate, and it's been inconclusive, then you've done everything you can. You can demonstrate that. I think it's just, as long as you've got that in place, then that's all you can reasonably do.
Thank you. And we've probably got time just for one more, but I'll just advise that any that have been submitted, we will be sending through a FAQ sheet later on in the next couple of weeks. So there will be opportunity to have your questions addressed. So final question just for today. What are the implications for social support or planned activity groups?
I think it's around, depending if they're internal or external, I think it's really important to be able to evidence that if the person has in residential aged care has ties within their community, that you're actually supporting them to maintain those ties, be it whether or not you actually take them out to that particular social support group or you try and insource. I think for people in a home care setting, it's trying to demonstrate that you're supporting them to maintain those ties to the best extent possible. If you're talking about internally, it's around making sure that you have considered the whole range of consumers, not just those who choose to turn up, and that you've got a balance of activities available that address the range of your residents' needs and preferences in relation to activities.
Thank you, Tina. So we'll just hand over now to Greg, who'll just close. Thank you again very much for your fascinating insights today.
Well, thank you, Tina, and thank you, Emily. Some very comprehensive slides there. I'm sure everyone will agree, and I think as touch points and for guidance, I think that they'll be very well received by the attendees. We will be sending those out to anyone that's registered to attend the website, including those that may not have been able to get on the day, because things do happen, as we all know, in the day-to-day circumstances of what we do. So yeah, the video presentation slides will be sent through to you probably over the next week or perhaps a little bit longer. Appreciating there might be questions that weren't answered, and if you do have any additional questions, please feel free to send them through. The email to send those to is info@pacecare.org.au. And if you can get those through to us, we'll be happy to pass those on to Tina, who I'm sure would be very happy to include some responses for us to send back out to everyone. Sincere thanks, Tina, for so generously spending this time to share your knowledge and thoughts with us all. And to Emily again for coordinating and directing today's webinar production. Thank you again to our attendees for your interest and engagement. We hope that you've found it informative and insightful. And I also hope that you'll join us for our next webinar, which I'm pleased to announce is going to be held on Wednesday, the 18th of August, again at 1 p.m. Australian Eastern Standard Time. So put that in your diaries. It will be able to be registered for fairly soon, if not this afternoon, then certainly we think tomorrow. We have a guest speaker, Bryce Innes, who's the Policy Services Manager for Warren Saunders Insurance Brokers. And he'll be guiding us through understanding workers' compensation. He'll give us an update on current insurance environment and insights on managing claims and minimising premiums. So registrations for the webinar to our website, pacecare.org.au. And if you'd like to learn more about how PACE can assist your organisation please feel free to contact me, Greg Worrell, through the contact details that will be provided with the presentation materials. Thank you, everybody. We appreciate your time, and I hope you gain some insights that are valuable to your business, and we'll see you again, hopefully on the 18th of August. Cheers.